All right, good evening, everyone. Let's start our today's tutorial. And we're looking at peripheral nerve blocks, the application in anesthesia and critical care. All right. So this will be our learning outcomes. All right. At the end of this tutorial, I expect everyone to be able to understand and explain the principles and indications of peripheral nerve blocks, to be able to describe the anatomy relevant to commonly performed nerve blocks. All right, they'll demonstrate the techniques of ultrasound-guided and landmark-based nerve blocks, recognize the applications of peripheral nerve blocks in anesthesia, pain management, and critical care. And we should be able to integrate peripheral nerve blocks into multimodal perioperative analgesia and enhance recovery pathways. So look at our outline. We'll follow this outline. So before we continue, let's just, as usual, try to answer these few questions. Okay, so the first one is, a 65-year-old man scheduled for shoulder arthroscopy receives an interscalene brachial plexus block. 30 minutes later, he develops shortness of breath and right-sided chest discomfort. What is the most likely cause of this complication? A, pneumothorax, B, phrenic nerve palsy, C, allergic reaction to local anesthetic, B, Horner syndrome, E, local anesthetic systemic toxicity. So what's the answer?
B.
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 Are you people sure you are not seeing my answers? Can you see my answer?
No.
No.
Oh, great. B. Correct. So, 2, which local anesthetic is associated with the highest risk of cardiotoxicity when used for peripheral nerve blocks?
Prof, the answers are visible.
They are visible.
Yes.
I knew it. Thank you.
Yeah.
Okay. All right. So, are they still visible now?
No.
Yes.
Oh,
Yeah.
Prof.
So, which local anesthetic agent is associated with the highest risk of cardiotoxicity when used for peripheral nerve blocks? A,
C.
lidocaine, B, ropivacaine, C, bupivacaine, D, mepivacaine, E, chloroprocaine.
C.
C, correct.
Bupivacaine.
All right. Okay. During ultrasound-guided femoral nerve block, the femoral artery is identified. Where is the femoral artery located relative to the, where is the femoral nerve located relative to the artery? Medial, lateral, posterior, anterior, deep to the artery.
Lateral.
B. Lateral. B.
Lateral, correct. All right. Remember the van, eh? A patient develops generalized seizures immediately after a brachial plexus block. What is the initial step in managing suspected local anesthetic systemic toxicity? A, administer IV lipid. 2, B, secure airway and provide 100% oxygen. C, administer benzodiazepine for seizures. D, start CPR. E, give intravenous epinephrine.
B.
B.
B. Prof.
B, correct. B is correct. Which of the following adjuvants is most commonly used to prolong the duration of peripheral nerve blocks without significant sedation? A, clonidine. B, dexamethasone. C, desmetomidine. D, fentanyl. E, morphine.
Dexamethasone. B. Dexamethasone. C. C.
B.
B.
Dexamethasone.
B. Dexamethasone.
C. B.
B. B.
Wait, some people are saying A, some people are saying B, some people are saying C. What is the
B.
consensus?
B. B.
B.
Dexamethasone.
Dexamethasone, Prof.
Are you sure?
C. C,
Yes.
because
Yes.
it doesn't offer sedation and no muscle.
I will take C. Any quarrel with C?
No, yes, sir. Dexamethasone can cause sedation,
Can
but
cause sedation
dexamethasone
now.
does not cause any sedation.
Sedation.
Okay. The answer is between B and C, but desmetomidine does not cause significant sedation. It causes a prolonged duration of analgesia. All right, it's an analgesic sedative, but it does not cause. So I will go for C. Please, can you mute your mic? Abdul Ahmed, please mute your mic. Okay, I will go for. Sorry, I've gone there. I'll go for C, guys. Where am I now? We are number 6. Sorry. Okay. Number 6. In which nerve block is the musculocutaneous nerve often spared, if not specifically targeted, potentially leading to incomplete analgesia? A. Interscalene. B. Supraclavicular. C. Axillary. D. Femoral. E. Sciatic nerve.
C. Axillary. Axillary, Prof.
Axillary, correct. Why? Why must we look for the musculocutaneous nerve? Any reason?
The branches go faster before the other.
Yes, it branches away earlier. All right, and it's not if you are targeting the axillary nerve sheath, you will miss the musculocutaneous. Where will you find it? Where will you find the musculocutaneous nerve?
In the belly of the coracobrachialis muscle.
Beautiful, in the belly of the coracobrachialis muscle, correct. All right, what is the preferred nerve block to provide analgesia for rib fractures in a patient with multiple trauma? What is the preferred nerve block to provide analgesia for rib fractures in a patient with multiple trauma? Interscalene block, supraclavicular, erectospinally plane block, femoral nerve block, tap block.
C.
Erector
C.
spine. Erector spine.
Beautiful. Beautiful. C. Which of the following is a contraindication to performing a peripheral nerve block? Patient refusal, coagulopathy with INR 1.5, controlled hypertension, diabetes mellitus, mild obesity.
A.
Patient
Patient refusal. A.
Patient refusal, correct. All right, during an ultrasound-guided supraclavicular block, which structure lies immediately inferior to the brachial plexus and must be avoided? A. Subclavian artery, subclavian vein, pleural, scalene muscle, phrenic nerve.
C. C.
Pleural. Pleural. C.
Beautiful, pleural. All right, because that's why you have pneumothorax as the most common complications of supraclavicular block. All right, and you know that supraclavicular block has been termed as the spinal block of the arm because of its dense motor block. Okay. 10. Which block will best provide surgical analgesia for a foot procedure sparing the medial ankle? Which of the following will best provide surgical anesthesia for a foot procedure when sparing the medial ankle, femoral, sciatic, popliteal, ankle block, saphenous nerve block.
Sciatic.
Yeah.
B.
C. Popliteal block.
B. Sciatic nerve block.
Sciatic nerve block B.
Medial part of the ankle, saphenous.
Saphenous block, correct. Saphenous block. All right, saphenous block is correct. Okay, so let's go. A peripheral nerve block, as we know, is a regional anesthesia technique which involves targeting administration of local anesthetic agent near a specific nerve or group of nerves to produce reversible loss of sensation of motor function in the area supplied by that nerve. The beauty of it is that it can be performed as a single shot technique or with a continuous infusion with a catheter for prolonged analgesia. There are three different techniques, approaches, which could be landmark-based, nerve stimulator, guided, or ultrasound guided. Guys, please mute your mics. Huh? All right, so historic aspect, we'll not go back there because of our time. Let's go to what we want. Okay, so what are the rules of peripheral nerve block in anesthesia and critical care? All right, provide surgical anesthesia for the extremities, truncal, and some head and neck procedures. Reduces or eliminates the need for general anesthesia, especially in patients with high risk. All right, it integrates, is an integral part of multimodal analgesia and enhanced recovery after surgery protocols, which reduces opioid requirements and consequently their side effect. All right, provides good analgesia for refractures and facilitates chest physiotherapy, thereby enhancing early weaning from ventilator. Okay, for patients who are unsuitable for systemic opioids and patients with that are contraindicated for neuralgia block, so you can provide peripheral nerve blocks for this group of patients. So let's look at the relevant anatomy. Okay, the first one is the brachial plexus. All right, understanding the anatomy of brachial plexus is important. Okay, so this is the brachial plexus. Don't forget, the mnemonic root means code there. All right, the root is C5 to T1, the arterial limb of spinal nerves. Don't forget that we can have the prefist and the postfist. All right, with contribution from C4 and T2 for the prefist and the postfist brachial plexus. The trunks, the T, are divided into the superior, middle, and inferior trunk. All right, okay, let's even see, I think I have the diagram. Let's look at the diagram from here. All right, so these are the common roots from C5 to C6, C7, C8, C1. So this is the root. The trunk, all right, it's divided into superior, middle, and inferior. The superior trunk is made by a combination of C5, C6 root, while the middle trunk is a continuation of C7. The inferior trunk is made by the combination of C8 and T1. Okay, so the trunks are divided into anterior and posterior. All right, so to form the division, the division, we have anterior and posterior division, and we have the cords divided into lateral, posterior, and medial cords. The medial cord is formed by the anterior divisions of the superior and middle trunk. All right, the posterior continues, okay, with the combination of the posterior divisions of the three trunks, okay, and the media, all right, it's formed by the posterior division and the anterior division, okay, and we have the branches, the terminal branches, Okay, we have 5 terminal branches: the musculocutaneous, axillary, medial, radial, and ulnar. Understanding this is important because you can target the root, trunk, division, cord, and branches in your brachial plexus block. Okay, so now there are different approaches for the brachial plexus block. Okay, we have 4 different, I call it Isaiah or Isaiah, whatever you want to call it. So the interscalene block targets the roots and the trunks, all right? That is from C5 to C6, and is best suited for shoulder and upper arm surgery. See, supraclavicular block targets the trunks and the divisions. So you can see, let's see this. So you can see that from the roots to the branches, the different approaches to brachial plexus block, is aimed at targeting the different areas. So the roots and the trunks are targeted by the interscalene. The trunks and the divisions are targeted by the supraclavicular. The cords, the division of the cord by the infraclavicular. And when you're doing axillary block, you're actually targeting the terminal branches of the brachial plexus. All right. So the other plexus is the lumbar plexus. All right. This is the plexus that innervates the lower limbs. Okay. It originates from T12, basically L1 to L5, but with contributions from the T12, all right, the ventral division of the lumbar spinal nerves. All right, this lumbar plexus resides in the lumbar region, specifically within the substance of the psoas major muscle, and they are anterior to the transverse process of the lumbar vertebrae. So the muscle, the major muscle there is the psoas major muscle, and that is where the lumbar plexus is located. Then there are different branches of the lumbar plexus. By now, I like mnemonics. So the 6 of them, the 6 branches of the lumbar plexus, I call it igifola, or you want to say I flog, okay? Igifola, the iliohypogastric nerve, which provides sensation to the lower abdomen and the groin. The ilioinguinal provides sensation to the groin and upper medial thigh. The genitofemoral nerve provides sensation to the scrotum or labia in women and the anterior thigh. The lateral femoral cutaneous nerve provides sensation to the anterolateral thigh. The obturator nerve supplies motor innervation to the adductor muscles of the thigh and provides some sensory innervation. The femoral nerve, which is the largest branch, is responsible for innervating the quadriceps femoris muscle, and while providing sensory innervation for the anterior thigh and the medial leg. The sacral plexus, all right, the sacral region, all right, is formed by the anterior divisions of the sacral spinal nerves from S1 to S4. Sometimes it can receive contributions, early contributions from the L4 and the L5 nerves. Okay, so we have about 5 key nerves of the sacral plexus. The sciatic nerve is the largest nerve in the body and is a major component of the sacral plexus, providing both motor and sensory innervation to the posterior thigh and most of the leg and foot. We have the superior gluteal nerve, which innervates the gluteus medius and minimus muscles, as well as the tensor fascial lata. All these nerves are important for hip abduction and stabilization. We have the inferior gluteal nerve, which supplies the gluteus maximus. All right, the posterior femoral cutaneous nerve provides sensory innervation to the skin of the perineum and posterior thigh. The pudendal nerve innervates the perineum and external genitalia, which plays a major role in the motor and sensory function. Then we have the truncal blocks, all right? Truncal blocks are regional anesthetic techniques which are used for specific areas of the trunk, which include the chest and the abdomen, all right? There are different types, Okay, the paravertebral block, which targets nerves as they exit the spinal column. We have intercostal block for rib fractures and chest surgeries. The pectoral nerve blocks, which is useful for breast surgery. All right. And then we have the TAP block, transversal abdominal spleen block, rectus sheath block, and what have you, and the rectus spinal plane block, obviously. Okay. Now, we mentioned there are different approaches to peripheral nerve block. Let's look at them. Look at this question, okay? Somebody quickly answer them. What are the three main approaches to performing peripheral nerve blocks? Compare all the three approaches in terms of safety, accuracy, and require expertise in a tabulated format. This would be a good short answer questions. So somebody, what are the three main approaches? How do you perform different techniques of performing PMB? Anybody, before we answer that? Anyone wants to give it a try?
There are three main ways, which is anatomical landmark, using
Landmark,
nerve
yes.
stimulator,
Landmark based, number one.
peripheral nerve stimulator,
Peripheral nerve stimulator, number two.
and an ultrasound guided.
Beautiful, ultrasound guided. Okay. All right. So if you see these questions, you should be able to answer that. Let's look at them. All right. The landmark-based technique. All right. This relies on the anatomical landmarks. All right. The palpation of the bone, muscular and vascular landmarks to approximate the nerve location. For instance, there are different types. For a femoral nerve block, you want to use your inguinal crease and the femoral artery. The same thing applies for your axillary nerve block. So, whether you're using landmark, peripheral nerve stimulator, ultrasound, anatomy, knowledge of anatomy is quite important. Landmark technique requires minimal equipment, all right? It's useful when you don't have ultrasound or nerve stimulator with you. However, it's associated with high failure rate due to anatomical variations, all right, and greater risk of complications. Nerve stimulator guided, all right? The peripheral nerve stimulator is useful, especially, all right, in areas where you don't have ultrasound, okay? And sometimes, a lot of us, I prefer to use both, okay? And when I was still very active in theater, I like to use both, all right, to increase, specificity and safety. All right, so let's quickly look at the nerve stimulator for those of us who have it, and it's a good expertise for us to acquire. So the peripheral nerve stimulator delivers low-intensity electrical impulses, usually between 0.2 to 1 milliamps, all right, with the duration of 0.1 milliseconds at a frequency of 1 to 2 hertz. All right, this is delivered through an insulated needle. All right, the principle is that when the needle tip is near a motor nerve, it causes visible muscle contractions in the corresponding muscle group. There are some key features of the peripheral stimulator. All right, we will have the stimulating needle. All right, we have the stimulating needle usually is specifically designed to deliver the current at the tip. We have the earthing needle, all right, which is usually attached to the part of the body. We have adjustable current output, which allows you to titrate from 1 milliamp down to 0.2 milliamps. Muscle twitch responses, which confirms nerve proximity. All right, ideal response is when you can still get muscle twitch at a current of between 0.3 to 0.5 milliamp. Now note that loss of twitch, all right, at less than 0.2 milliamp indicates that most likely your needle is intraneural, all right, and you may need to withdraw your needle. Okay, so this is a peripheral nerve stimulator on the right side of the screen. Okay, so what you do, you set the nerve stimulator to 1 milliamp, all right, at 0.1 milliseconds at frequency of 2 hertz. All right, so this is the earth, this is the stimulating needle. Okay, you advance your stimulating needle towards the target area where you're observing for muscle response, okay, contractions. All right, when you obtain that, you want to reduce your current to 0.3 to 0.5 milliamps. And when you still get the muscle twitches, you need to, that's where you inject your local anesthetic agent, all right, after you have ruled out intravascular, um, placement, okay? So it's important. You don't inject at 1 milliamp because you may still be very far from the nerve proximity, all right? So once you get a desirable twitch at 0.3 to 0.5, that shows very close proximity to the nerve, and it increases your chances of success of block. So advantages, it enhances accuracy over landmark technique, useful when ultrasound is not available, and is possible and not expensive. All right. The limitations, obviously, it does not visualize nerves, so you can do your early deposition under direct vision. And some patients, especially patients with neuropathy or patients under muscle relaxant, you may not be able to elicit desirable muscle response. And there's risk of intraneural injection, like we mentioned before, if you're not careful. Now, the ultrasound guided technique uses your high frequency linear probe, all right, and it's used to generate real-time images of your target nerve, adjacent versus muscles and the fascia. All right, the needle is then visualized as it advances towards the nerve, and local anesthetic is injected under direct vision. You'll see the nerve swell. All right, that's what we call the hydrodissection. We're going to come to that. All right, so how do you perform ultrasound guided nerve blocks? You want to select the appropriate probe, all right, for superficial structures, linear. Sometimes if you want to do deeper nerve blocks, all right, you may want to use your curvilinear. Okay, identify your target nerve, and this is where anatomical knowledge, all right, is important. Knowledge of anatomy. Okay, identify the target nerve and surround the anatomy, and the nerve will appear like a honeycomb, all right, hypoechoic structure, all right, and especially if you are using in-plane technique. So inside the needle in in-plane parallel to the probe, and advance your needle under continuous ultrasound guidance. So what you do once you are able to identify the honeycomb appearance of the nerve, you want to first of all give about 1 to 2 minutes of normal saline, and you'll see, all right, the donut sign, the nerve will swell up, or what we call hydrodissection. You want to do this before you deposit your local anesthetic agent. And once you do that, you'll see the nerve spread out, all right? The local anesthetic agent spread out into the nerve. All right, the advantages are numerous. Direct visualization of the nerves. You see the needle go into your target nerve, and you will see the spread of your local anesthetic agent under direct vision. This helps to improve block success rate and also ensures faster onset of action. It causes reduced risk of vascular puncture, pneumothorax, or nerve injury. And because of accurate deposition, it requires lesser volume of local anesthetic agent. In patients who have anatomical variations, all right, or patients with obesity, distorted landmark, and scarring, ultrasound guidance helps. Now, the limitations, you remember that it has a steep learning curve, so it requires training and experience, all right, especially in identifying your neurovascular bundles. All right, this may be expensive in some settings, okay? And needle visualization may be difficult, especially when you're doing deeper blocks or patient with obesity. And more importantly, ultrasound guidance technique is operator dependent. Okay, so techniques for individual peripheral nerve blocks. Let's look at the upper extremity blocks or the upper limb blocks. All right, so let's see who will make an attempt. Frank answered that first question. So let's see who will help us with this one. A patient is scheduled for surgery on the forearm. As the anesthetist, you are considering an axillary brachial plexus block for both intraoperative and postoperative analgesia. Number one, name the component of the brachial plexus in correct order from proximal to distal. All right, anyone? Anyone? Let's see. These are likely exam questions. Who is trying to take a go for it?
So we have root.
Okay, root.
Then chord. Then
Root and
division.
chord, no? Remember, what did
We
I
have
say?
a-
Root
we
to
have
me
root.
drinks cold beer. Root,
Yeah, we have root. Tracks.
tracks,
Yeah, we have codes,
chord,
divisions, and branches.
what comes? Chord or division? Division comes before chord.
Yes.
Okay.
Okay? Remember,
Yeah.
I said root to me drinks cold beer. Arrow, root, C5, all right, to C8, trunk, T, okay? Then drinks, division, code, chord, okay? Beer, branches, okay? Now, who can list the terminal branches of the brachial plexus? Terminal branches?
So we have the median nerve, the ulnar nerve, the radial nerve, and the musculoskeletal nerve, musculocutaneous nerve.
Okay, there are 5. The axillary nerve is there. So I normally use the mnemonics Mr. Amu. Okay, Mramu, Mr. Amu. Okay, musculocutaneous, radial nerve, axillary, medial, and ulnar nerve. Okay. Now the question: which cords give rise to the following nerves? Okay. Now, describe the anatomical landmarks and position for performing an axillary nerve block. Anybody? Joseph, are you trying to say something? How will you perform an axillary nerve block? Anyone? What are the anatomical landmarks? Okay. Everybody has gone to sleep on me now. Ugingo, Joseph, are you trying to say something? If you are not, please mute your mic.
Yes, Prof. For musculocutaneous comes from lateral cord,
Okay.
median from posterior division, and ulnar nerve from medial cord.
Okay. There are 5 terminal branches. Okay, good attempt. Tapiwa, you want to chip in something?
Sorry, I wanted to try D.
Go ahead.
I thought the anatomical landmark, you palpate for the axillary artery.
Okay.
And yes, then
Start
you
with your
advance.
patient positioning. How will you position your patient?
You position the hand externally rotated with the elbow flexed at 90 degrees.
Okay. Go ahead.
That's right. That's as far as I can go. All I know is you go for the axillary artery and then you advance your needle until you feel a pop and then you know that you're within the sheath.
Okay, good attempt. Will you want to
yes,
go through? Do you want to go through the axillary artery, or you want to just fill a pulp and you deposit? With that, are you sure you'll be able to target all the terminal branches?
You first pull back the plunger to make sure that you're not within the artery. And then it targets all the nerves except the muscular lateral cutaneous nerve.
Musculocutaneous nerve, okay. Good try. So what are the advantages of the axillary nerve and the two limitations?
Prof, I want to try.
Okay, Hosea, go ahead.
Okay, so compared to other upper limb blocks like interscalene and supraclavicular blocks, axillary block is generally safe and low risk of complications since it is very distant from the potential structures like pleura and major blood vessels. So it's reducing the risk of having pneumothorax or potential having last and inadvertent intravascular injection. That's one. Two is very good for the distal upper limb surgeries. For example, the surgeries that involve the forearm, waist, and the hand. However, it's limited because one of the terminal branches of brachial plexus need to be separated, need to be blocked separately, the musculocutaneous, because you have to go in the lateral to find it have its own block, and most of the time it's missed, and some patients can experience pain on the lateral aspect of the forearm, the skin, and so it can hinder techniques like tourniquet application. Yes, so also it is not suitable for surgery that they involve the arm, especially the upper mid of the arm area, the mid-humerus surgeries and other. And yes, that's my try, Chief. Thank you, Prof.
Beautiful, good try. Okay, so let's look at our lecture. Frank, are you saying something?
Yes, for axillary block, compared to interscalene, we are not going to block the phrenic nerve, so it has that an advantage. But also, I wanted to try the see those terminal nerves, where they come from, which cause.
Okay, go ahead.
Yeah, so musculocutaneous nerves came from lateral cord. Median nerves came from combination from lateral and the median cords. The radial nerves came from posterior cord, and the ulnar nerve came from medial cord.
Good try. Okay, so let's look at the individual block. All right. Remember I told you Isaiah. So let's look at the interscalene block. Okay. Like we said, from the proximal to the distal, the interscalene block targets the roots and trunks, all right, of the brachial plexus, all right, between the anterior and middle scalene muscles. So you position your patient supine with the head turned on the other side. You want to locate the sternocleidomastoid muscle and the interscalene groove at the sixth cervical vertebrae. So identify if you're using an ultrasound, you want to, which is better, all right? You want to identify the nerve roots, all right, between the scalene muscles. You use the plane, all right? And after you identify, you want to deposit 10 to 15 minutes of long-acting local anesthetic agent. All right, this interscalene block provides excellent anesthesia and analgesia for shoulder and upper arm surgery. But remember that it has a high risk of phrenic nerve block, so you need to look out for this, especially post-op for respiratory distress in your patient, all right, and unilateral chest discomfort. So this is an ultrasound image, okay, of look at the probe pointed towards the patient's head, all right, and you want to do this, and you locate the nerves. The nerve has the honeycomb here, okay, and this is where you direct. You want to do in plane or out of plane, okay. You direct. If you are, this is out of plane. If you put your needle here, or you can direct your probe marker cephalad, all right, and you can put it in plane. It's important. These are the two scalene muscles, and the nerves are located between the interscalene groove. Okay, for this procedure, it's better you use an ultrasound. You don't want to use landmark because of the high risk of phrenic nerve damage. Okay, so the second one is the supraclavicular block. All right, the supraclavicular block targets the trunks and divisions of the brachial plexus in the supraclavicular fossa. All right, you want your patient to be lie supine with the arm adducted, head turned contralaterally. All right, locate the clavicle and the subclavian artery. Okay, the brachial plexus is usually lateral and superficial to the subclavian artery. So the subclavian artery becomes your landmark, okay, and the pleura is just below it. You remember the questions we saw earlier on. Okay, the supraclavicular block is usually referred to as the spina of the arm because it provides dense anesthesia for upper limb. But note, because of the position of the pleura, all right, just below the subclavian artery, all right, the risk of pneumothorax becomes an issue. Okay, so this is the clavicle, supraclavicular, about 1 to 2 centimeters above the clavicle. Okay, and this is in plane. You see here the probe marker is towards the head, medial aspect, and you put your needle here. And once you locate the what's it called, subclavian artery, lateral to the subclavian artery is where you deposit your local anesthetic agent. Okay, we have the infraclavicular block. All right, this locates the cords. Okay, and here you use the axillary artery as your landmark, and the cords. All right, the posterior, lateral, and medial cords of the brachial plexus usually surround the axillary artery. All right, at this stage, okay, at this point rather, you want to inject about 20 to 30 mils of local anesthetic agent. Okay, the infraclavicular block is suitable for surgery below the mid-humerus, and it has low risk of pneumothorax because we are avoiding the pleura at this point. All right, so this is the infraclavicular. All right, 1 centimeter, 1 to 2 centimeters below the clavicle. Okay, and you locate the axillary artery, and around the axillary artery are the lateral, medial, and posterior cords, and that's where you deposit your local anesthetic agent under direct vision. Now, the axillary block targets the terminal branches around the axillary artery, like I told you, the Mr. Amo, or musculocutaneous, radial nerve, the axillary nerve, medial, and other nerve. Patient is posterior supine with the arm abducted at 90 degrees and the elbow flexed. So you want to palpate for the axillary artery in the axilla, all right? And you want to locate the other 4 nerves, the medial, ulnar, radial nerves surrounding the axillary artery, all right? And like we said, the musculocutaneous nerve is in the belly of the coracobrachialis muscle, okay? You want to deposit about 15 to 20 mils of your local anesthetic agent. And after you have blocked those 3 nerves, you want to go laterally into the body of the coracobrachialis muscles to look for the musculocutaneous nerve for it to block, okay? It's safe, all right? The axillary nerve, like we mentioned before, All right, minimal risk of diaphragmatic involvement, phrenic nerve, and pneumothorax is the risk is reduced, okay, and is useful especially for the forearm and the lower arm. I mean the forearm and the wrist, okay, and it usually provides a very dense block for these structures. All right, so this is the axillary artery. All right, the ultrasound probe is located in the axilla, and this is where you look after palpating for the axillary artery. I remember those days we used to do landmark. You know, there are different ways we used to do landmark technique. For those of us who do not have ultrasound, palpate the axillary artery, okay? And most of the times we intentionally pierce the artery, and you know, once you aspirate, you go further in, and when there's no aspiration, you deposit about 5 to 10 mils of a local anesthetic agent posterior to the axillary artery, and then you come out gently, all right, aspirate, and once you can't, there's negative aspiration, you deposit the other 10 mils of your local anesthetic agent to block the other nerves in the axilla. Okay, so I hope you understand that. You know, there are usually about 2 pops that you feel, okay, and that is for landmark technique. But in the advent of ultrasound, you can actually use your ultrasound, you know, in the axilla, locate the axillary artery, and you know, around the axillary artery, the 3 cords that you require to block. Okay, lower limb blocks. Let's see, there's a question here. An 85-year-old hypertensive woman fell while walking down the stairs and sustained a lower limb fracture. Due to her age and comorbidities, spinal and epidural anesthesia had to be avoided. So, A, list the 5 peripheral nerve blocks that may be considered for surgical anesthesia in this patient. Describe the anatomical landmarks and techniques of any one of the listed blocks. All right. What are the advantages of using ultrasound guidance for peripheral nerve blocks in elderly patients? List 3 contraindications to peripheral nerve blocks, and what are the possible complications of performing multiple nerve blocks in this setting? Okay, so let's just answer only question A. What are the 5 peripheral blocks that you can consider for this patient because you are avoiding spinal and epidural? Anyone, quickly? An elderly hypertensive woman with lower limb fracture. Which peripheral nerve blocks can you consider for her case?
Sciatic nerve block, sir.
Sorry?
Sciatic nerve block.
Sciatic nerve block, number 1. Number 2?
Fascia iliaca.
Fascia iliaca
Obturator nerve
compartment block. I'll take number 3.
Obturator nerve block.
Do you block obturator nerve separately, or is part of the fascia iliaca compartment block?
3 in 1 block.
You can do 3 in 1, which is femoral, obturator, and fascia iliaca at the same time.
No, I don't agree with you. The fascia iliaca is not part of your 3 in 1. Fascia iliaca is similar to 3 in 1, but the 3 in 1 block is femoral, okay, obturator, and lateral cutaneous nerve, all right? Lateral cutaneous femoral nerve, okay? Do you understand that?
Yes.
Okay, which other blocks? We have mentioned 3 now.
You can do saphenous at adductor canal.
Yeah, adductor canals block. Or what is the other name for adductor canals block? Hunter's block, isn't it? Hunter's block.
Yes.
All right. What is the advantage of the adductor canals block? Anyone?
It spare quadriceps of the femoral, so a patient can
Beautiful,
emulate it.
beautiful. Frank, are you sure you are not a fellow, or you have not done post-fellowship training, what's it called? Regional. You look like a regional guy.
I'm at MUHAS, Prof.
Sorry?
I'm at MUHAS, Prof. MUHAS student.
The way you are answering, beautiful, beautiful. The saphenous block or the adductors block is purely a sensory block, all right? The quadriceps muscles, all right? Which of the blocks, you have not mentioned, which of the blocks can actually cause, quadriceps palsy?
Femoral nerve block.
Femoral nerve block. Femoral nerve block. All right, good question. Okay, so if you see this question in the exam, you'll be able to answer it. Right? Some people are not talking today. Where are the people? Will you be able to answer these questions? Is it a fair question if you see this question?
Yes.
Yes, Prof. It's a fair question, Prof.
Okay, good. All right, so the femoral nerve block. You can actually block the femoral nerve alone, okay? And cause quadriceps weakness, which can lead to risk of falling. Okay, femoral nerve block, very easy to perform. You can use landmark, you can use ultrasound, okay, indicated for hip, thigh, and knee surgery, and especially even for post-operative pain relief. The patient is lying supine. The same way you use femoral femoral vein catheterization. All right, look at the inguinal crease 1 to 2, finger breadth below that, locate the femoral artery, the position of the femoral artery. Instead of going medial to look for the vein, you go lateral, all right? And if you are using nerve stimulator, you can see the quadriceps muscle twitch, okay? And if I use ultrasound, I go the alveolar nerve, which is lateral to the artery. There you deposit 10 to 20 mils of your local anesthetic agent. Okay. Always bear in mind the risk of fall for quadriceps weakness. Okay. The fascia iliaca block is a feed block or compartment block that aims to block the femoral nerve, lateral femoral cutaneous nerve, and often the obturator nerve. All right. And the local anesthetic agent is delivered beneath the fascia iliaca. Okay. And how do you do that? This is important. Okay. It's similar to 3-1 block. All right. But for fascia iliaca, the local anesthetic agent is actually deposited beneath the fascia iliaca. Okay. So it's good for analgesia for hip and femoral fractures. And you identify the anterior, let's see. So you identify the anterior superior iliac spine and the pubic tubercle. Okay, you draw a line between the two structures and between the junction of the lateral 1/3 and medial 2/3 is where you insert your needle. All right, and you should feed 2 pulses as to pierce the fascia lata and the fascia iliaca. All right, and once you do that, once you pierce the fascia iliaca lateral to the femoral artery, you deposit about 30 to 40. It's a high volume block because a compartment block. Okay, and this is how you do it here. Okay. The sciatic nerve block usually indicated for surgery below the knee, and sometimes is combined with femoral block, all right, for complete lower limb anesthesia. There are 3 approaches. We have the Lambert approach, which is the classical approach. You put your patient in the lateral decubitus position. The operative side is up with the hips and knees flexed. This actually allows for patient's comfort. I draw a line to connect the greater the greater trochanter of the humerus and the posterior superior iliac spine. All right, from the midpoint, this is it here. This is the greater trochanter of your humerus and the posterior superior iliac spine. I draw a line, and at the midline, you want to get about 4 centimeters, and this is where you put your needle. Okay. Okay, so from this midpoint, draw a perpendicular line caudally, like we mentioned. You can actually use the popliteal approach because the sciatic nerve lies lateral to the popliteal tree, just above the popliteal crease. Usually posterior patient prone or lateral. It's easier while using ultrasound. Okay, and for this you need to avoid intramural injection. See the saphenous adductor canal block, all right, which is named after the Hunter, who is a Scottish surgeon who actually did a lot of work on anatomy and surgical anatomy. All right. Now, but one of the things you need to know is that this spares the quadriceps is predominantly a sensory nerve block. Okay. For the medial leg and ankle analgesia. Okay. And because of our time, you can read this later on. Okay. And landmark technique, you can use both ultrasound and landmark technique. For the landmark technique, you want to locate the midpoint between the anterior superior spine and the patella. And just there, you want to feel the bulge of the sartorius muscle. You insert your needle just medial to the sartorius, deep to the facial lata. Okay. And the advantage of the adductor canal is that it preserves body strength, okay, and reduces the risk of falling. Ankle block, this is important, especially, for surgeries below the ankle. And there are 5 nerves that are usually blocked in a ring faction. All right, call them SPSS, the saphenous nerve, the peroneal nerve, the superficial peroneal nerve, the posterior tibia. Okay, usually good for foot and toe surgeries. Okay, there's no need of doing more blocks if you can do ankle block. 5 mil of local anesthetic agent per nerve. Our time is up. We have Truncal block. Let's quickly answer these questions, and maybe we can end it here. Okay, so a 50-year-old male patient undergoes open abdominal surgery. As part of his post-operative pain management plan, truncal nerve blocks are being considered. So answer the following question. What is truncal nerve blocks? And give 2 examples. Number 2, outline the anatomical location and clinical indications of transversus abdominal spleen block. Number 3, what are the key differences between PEC 1 and PEC 2 blocks? And number 4, these are the 2 advantages and 2 limitations of using truncal nerve blocks. Anybody wants to try this? Anyone? Are we familiar with truncal blocks?
Prof, let me try.
Go ahead, Ozaya.
Okay, so a trunk nerve block, just from the word trunk, can be used as it's usually a nerve block that it doesn't target a specific nerve, rather it targets a group of nerves. So they are usually used for postoperative analgesia or sometimes surgical anesthesia. So the main thing is that they do not target an individual nerve, however, they target a nerve plexus or the group of nerve to cover a broad area in the chest or the abdomen. For example, the paravertebral block, which targets the spinal nerves in the paravertebral space. It can be used for thoracic surgery or during the mastectomy and surgery. That's maybe when somebody have rib fractures. The rectus spine blocks, also TAF block is one of them, and the rectus chest block. That's like a little bit of an idea. Maybe other they can add more.
Beautiful, beautiful. Are you from Wuhan too?
Yes, Prof. I'm from Wuhan too.
Okay. All right.
Yeah,
Great try. Great try. Okay. What are the key differences between PEC 1 and PEC 2 blocks? Anybody? Okay, our time is running. Let's see. Okay, so this is the paravertebral block. Okay, like he mentioned, like Josiah mentioned, it adjusts spinal nerves as they emerge from the intervertebral foramina. All right, most of the paravertebral block will do is the thoracic, but you can also use the lumbar and the cervical block. Okay, ultrasound guidance is very important, but remember that pneumothorax and hypotension can occur due to inadvertent epidural spread. Then the pectoral nerve blocks, all right? We have PEC1, PEC2. The PEC1 is a block between the pectoralis major and minor, and it's used to block lateral medial pectoral nerves. All right, this is usually useful for breast surgery. And you can also have PEC2, which blocks pectoralis minor and serratus anterior, which is deeper, all right, and can block intercostal nerves also. Okay. Ultrasound guidance is usually better for this block. Well, the rectus sheath block, okay. Time is going quadratus, temporium block, serratus anterior block, and intercostal nerve block. There are two things block I want us to actually spend time on: intercostal and the tap block. Okay, so look at this question, for instance. A 55-year-old male patient with multiple rib fracture presents to the emergency department with severe pain and respiratory distress. So the first question is, describe the anatomical features of the first rib. Okay. 2, list 3 important structures that lie in close proximity to the first rib and are at risk during interventional procedures. State the indications for intercostal nerve block in trauma patients. Outline the steps involved in performing an intercostal nerve block, and mention 2 potential complications of an intercostal nerve block and how to minimize them. All right, is this a fair question if you see it in exam?
No, it's not.
It's not fair.
Yeah, right now, for me right now, it's not fair.
Any other person? Frank Mijan.
Yes.
Is it a fair question?
It is fair.
Okay. All
Yes.
right. Any other person that is not from Mohans? Where are my Kenyan people? Diana, are you here?
Yes, Prof, I'm here. I am here.
Can you answer this question?
Oh, Prof. The ribs. Oh. This is a tough one.
Okay, where are my Niger people? Where are the people from Nigeria? Where are you guys? Monday.
Sir, Prof, good evening, sir. I'm with you, sir.
Yes, I know you're with me. What do you think about this question?
It's fair, sir.
It's fair?
Yes, sir.
Okay, good. So try and answer it.
Sir, I will start with the anatomical features of the first rib.
Actually, guys, you know that this question is actually in one of my books. All these questions I'm bringing out, they are from my books. Okay? They are from my books. So our time is fast spent. Monday, thank you for trying to attempt, but I think our time is fast spent. Okay. Indications for intercostal nerve block is intercostal. Then the ICU, insertion of chest tube, nephrectomy and post-nephrectomy, thoracotomy, breast surgery, and all of that. Okay, landmark technique, you can use ultrasound All right, these are both landmark ultrasound technique for intercostal nerve blocks. Okay, you want to avoid vascular puncture. Okay, and transversus abdominal spleen block. I'm sure we are aware of this, and it's a very good regional anesthetic technique. We target the nerves of the anterior abdominal wall. Okay, and time is gone. All right, so look at the subcostal margin and the iliac crest. This in between, this is where you want to perform your tap block. Okay, the erectospinal block. Okay, and so complications of nerve block, as we round up, it can be mechanical. All right, nerve injury, hematoma infection. Okay, it can be pharmacological. All right, you can have your local anesthetic systemic toxicity. All right, you can have block related, the block can fail. You can have paralysis of the phrenic nerve, Horner syndrome, especially after interscalene block. All right, so how do you prevent complications? So you want to do comprehensive pre-block assessment. You know, use ultrasound as much as possible. Give a correct amount of those, okay, and avoid the vascular injection. Do your checklist and all of that. Okay, let's stop here because of our time. Any question? And we'll just round up in the next 3 to 5 minutes. Any